All right, let's talk about Corynebacterium mucifaciens. We've put this whole explainer together using Gemini Deep Search, and if you want to see the complete list of sources, you can check out the accompanying notebook document. Okay, let's get right into it.
You know, this quote, I think it just nails it. It really gets to the core of the story here. For decades, we'd see these diphtherioids in a culture, and what did we do? We dismissed them, called them contaminants, skin flora, just junk. But our technology now is forcing us to take a second look, and we're realizing we might have been tossing out the culprit all along.
So, here's our game plan. We're going to follow a classic bench-to-bedside path. We'll start with its story, figure out how to spot it in the lab, understand the diseases it causes, then tackle how to treat it, and finally, how to prevent it.
All right, first up, let's start with the absolute basics. What exactly is this bug? And what's with that very descriptive name? Okay, so at its heart, it's a gram-positive rod. It's one of those bacteria that just hangs out on our skin, part of the normal crew. It's a risk group 2 organism, which basically means, yes, it can make people sick, but it's not likely to be a major hazard to us in the lab. But, and this is the key, when you find this guy in a place it has no business being, like a blood culture, that's when the alarm bells really need to start ringing.
So, taxonomically, it sits right where you'd expect, in the Corynebacteriaceae family, but the name, mucifaciens, that's where it gets fun. It's straight up Latin for slime producing, and that pretty much tells you everything you need to know about what it looks like on a plate. It's a huge clue, and we are definitely going to circle back to that.
Okay, let's head over to the lab bench. This is where things get really fascinating, because the way this bug typically looks, the very thing that makes you go, aha, I know what this is, well, it can actually lead you right down the wrong path.
So, you get a plate. Your gram stain shows those classic pleomorphic corniform rods, right? The little V-shapes and palisades, the whole Chinese letters appearance. On blood agar, you see these gooey, yellowish colonies. Quick biochem check, catalase positive, oxidase negative. At this point, you're feeling pretty confident. These are all really strong presumptive clues.
But, and this is a huge but for every single person working in a clinical lab, what if it doesn't look like that? Atypical strains exist. They're non-mucoid, kind of whitish, and they don't fit the textbook picture at all. And the really scary part, these atypical variants have been isolated from fatal cases of bacteremia. This means you absolutely cannot rely on colony morphology alone to make the call or to dismiss it.
So, that brings us to the modern playbook for identification. Step 1, sure, it's your presumptive ID from the gram stain and what it looks like on the plate. But that's just the start. Step 2 is confirmation with MALDI-TOF mass spec. And listen, you have to do the protein extraction step. Don't skip it. Finally, for any critical isolate, anything from a sterile site, anything that just looks weird, you have to go to the gold standard, gene sequencing. Get that RPOB sequence, and then you'll know for sure.
Okay, so we've got a solid ID. What does that actually mean for the patient? Let's jump over to the clinical side of things, because the range of diseases this bug can cause is, well, it's probably a lot broader than you might think. Most of the time, you're going to see it pop up in bacteremia, usually linked to an indwelling device in an immunocompromised patient. That's its classic move. But it is not a one-trick pony. We're talking severe lung infections, like necrotizing cavitary pneumonia. We're talking metastatic infections, where it seeds the brain and causes septic emboli. And of course, you've got all the localized stuff, wounds, abscesses, joints, you name it. And this is where we have to challenge that simple opportunist label. There's this landmark case of an immunocompetent guy. His only real risk factor was well-controlled diabetes, but he had intense exposure to farm dust, which we know can be a reservoir. This suggests that if you get a high enough inoculum, a big enough dose, this bug can potentially overwhelm the defenses of a relatively healthy person.
Which brings us to probably the most practical, most urgent question for everybody involved, from the lab to the clinical team. We've identified it, now what? How in the world do we treat it?
So picture this. You've got a significant isolate of Corynebacterium mucifaciens from a blood culture. It's on you. Where do you turn for the official, evidence-based guidelines on how to treat it?
The stark reality is you can't. They don't exist. You can check IDSA, ESCMID, the Dutch swab. There are no specific guidelines for this particular organism. We're in a guideline vacuum. And that elevates the role of the lab's antimicrobial susceptibility testing, the AST, from being just important to being absolutely essential for patient care. It's the only real map you have.
Now, large surveillance studies on the broader group of non-diphtheriae Corynebacteria do paint a pretty clear picture. Just keep in mind that interpretive breakpoints, like from EUCAST, are still kind of limited for this group, but the data shows really high rates of resistance to drugs like penicillin and ciprofloxacin.
In contrast, other agents look much more reliable. And this right here is the critical takeaway for your initial empirical therapy. In a study of nearly 2,000 isolates, susceptibility to vancomycin and linezolid was 100%. That makes them the cornerstones of treatment while you're waiting for those definitive AST results to come back from the lab.
So without specific guidelines, we can extrapolate. A good framework to borrow from is the Dutch SWAB guideline for prosthetic joint infections. It gives us a logical plan. Start empirically with IV vancomycin with drug monitoring. If the AST shows it's susceptible, you can de-escalate to a high-dose continuous infusion of benzylpenicillin. When it's time for an oral switch, you've got options like amoxicillin, levofloxacin, or doxycycline. And for a straightforward bacteremia where you've got source control, 10 to 14 days of therapy is generally enough.
Internationally, the story's the same. Treatment has to be driven by your lab's AST data. For kids, the situation is even more stark. There's a complete lack of pediatric guidelines. Management has to be carefully extrapolated from adult data. And across all patients, one principle is absolutely fundamental to success: source control. You have got to get that infected catheter out.
So finally, let's close the loop. This organism lives on our skin. So how do we prevent these infections from even starting?
First, it is vital to make this distinction. This is not Corynebacterium diphtheriae. That's the infamous one that needs droplet precautions. Corynebacterium mucifaciens is transmitted by autoinoculation from the patient's own skin. That means all you need are standard precautions.
This means prevention really hinges on meticulous, fundamental practices. The absolute cornerstone is hand hygiene. Then comes strict aseptic technique during any invasive procedure, especially inserting and maintaining lines. Routine environmental cleaning helps, but patient isolation isn't necessary. It's a total return to basics, but it's absolutely vital. Hey, we'd be interested to hear about your specific IPC measures in the comments. And of course, if you find these explainers useful, please like and subscribe for more.
The story of Corynebacterium mucifaciens is such a powerful reminder that our understanding of microbiology is always evolving, driven by the tools we use. And it forces us to ask a really interesting question. As our diagnostic technology gets even better, which organism that's currently sitting in the contaminant pile will be the next one to be recognized as a true pathogen?